Hello all. We're going to talk about GI Poopouri. As you know, it's not all in the name. What we're going to talk about today is technique of submucosal saline injection during endoscopy, indications, contraindications, and techniques of tattoo injection, and how to identify and classify Barrett's esophagus. Why I chose these three topics? Because during endoscopy, I do see some mistakes made, some lack of understanding in classifying Barrett's esophagus, how to do the saline injection, and what are real techniques and indications for tattoo injection, and that's why we are here. Let's jump right into injection technique. Before I get into that, I also want to acknowledge my dear friend Dr. Raju from MD Anderson Cancer Center, who provided me quite a few slides of his for this presentation. So first things first, always hold the syringe facing down. Holding the syringe down avoids the injection of air, as we all know that air floats to the top of the syringe. So what are the steps to inject saline solution? Step number 1 is to take a 10 cc saline syringe and clear the air bubbles. Attach the syringe to the injection needle, catheter, flush the catheter until fluid comes out. Keep the needle in before giving the injection catheter to the endoscopy. It is very, very important that your needle stays in when you are handing it to endoscopist. If the needle is out and endoscopist starts putting the needle in the therapeutic channel of the scope, then you can damage the scope, and it's a pretty expensive $10,000 repair. Once the injection catheter comes into view, pull the sheath back to expose the needle when the endoscopy says needle out. Then flush the syringe again by gently tapping, just tapping on the plunger, not injecting. Hold the syringe facing down to avoid injecting air bubbles like we talked about before. Once the endoscopist punctures the wall, push on the plunger to inject fluid into the submucosa. Inject saline rapidly at that point while endoscopist changes the direction of the needle. I see that a lot of nurses or techs, they will keep on looking at their syringe and talking about the volume. Really, it's not necessary. It's necessary that you watch the screen and see how the saline injection is going, and your endoscopist is using a dynamic technique to really get the saline underneath the lesion of choice. Injecting saline below a flat or sessile polyp lifts the polyp, as you know, away from the muscle and blood vessels, which prevents the capturing of the muscle and perforation of the GI wall during snare resection. So there are some problems sometimes that happen with submucosal injection. One is that instead of submucosa, injection is in the mucosa, and you can see some mucosal bleb, but you don't really see a submucosal translucent bleb. At that point, stop the injection, and in order to avoid creating a large mucosal bleb, tap on the plunger. Just little tap, not injecting again. So let the endoscopist puncture the deep into submucosa and restart injection. Again, watch the screen, don't watch your syringe. Restart injection to create a submucosal bleb. Tap on the plunger again and see how things are going, whether it's submucosal or mucosal. And once the submucosal bleb is confirmed, inject quickly at that time. There's sometimes you will have a injection which is extramural space. At that time, you will not see any kind of bleb, either mucosal or submucosal. At that time, just tap the plunger and see if any bleb you see. If you don't see, then let the endoscopist reposition the catheter and then do the injection. Moving right into tattooing, why is it important to do the tattooing correctly? To really avoid the unfavorable outcomes. One is, if your tattoo is incorrect, there will be a misleading guidance from endoscopist to the surgeon, and wrong segment can be resected, or some other problems will happen. And second issue is that if you're doing tattooing too close to a polyp, this will result in submucosal fibrosis, which is basically scarring under the polyp, and that will make the polyp difficult to remove, and it will also increase complication risk, such as perforation and incomplete resection as well. So there was a very nice article in Clinical Gastroenterology and Hepatology this year. This was the International Delphi Agreement, where basically 29 experts were contacted. They participated. It's an international panel, people who do a lot of endoscopic mucosal resection. This was a 3 rounds of Delphi process where multiple statements are given, and then see what happens with concordance. And based on concordance of the first step, second step, and then third step, the final recommendations are made. So 3 questions were asked. One was where tattooing should not be used. Second was where tattooing should be used. Third is how to perform tattooing. So a total of 15 statements were formulated, and we'll discuss all those statements. So first one is very clear, where tattooing should not be used. Tattooing should not be used in the cecum, as cecum has its own natural landmarks, and we can clearly see where the polyp, and then we can just mention the polyp. There's no need for tattooing in the cecum. In general, tattooing should not be used in the rectum unless it's difficult to detect. We know that rectum has 3 valves of Houston. You can very clearly tell the endoscopist, we're referring the patient, whether this is close to the anal verge or first valve of Houston or second valve of Houston. So there's no need to really do the tattooing in the rectum. Where tattooing should be used. Endoscopic diagnosis of a deep invasive cancer. Whenever you diagnose a cancer, you know this is a cancer. Looking at it, an experienced endoscopist can really tell. At that point, you want to tattoo, and I'll discuss the technique when you discover a cancer. I'll discuss technique how the tattooing should be done in that scenario. After endoscopic resection of a lesion with suspicion of submucosal invasion, sometimes when as endoscopists we see that, okay, there is a very flat surface on top, there's a nice classification 3 kind of polyp where there's very amorphous kind of granularity at top of the polyp, and there may be submucosal invasion in that, and then if you want to really identify this lesion in future, tattoo should be done. If a general gastroenterologist find a colorectal lesion that's left in situ, which is not removed but is considered suitable for endoscopic mucosal resection, then tattooing may be used if lesion is considered difficult to detect, like in the transverse colon and the ascending colon. But sometimes lesion is pretty really apparent, like 2 valves or 2 folds from the cecum. You know it's in the ascending colon. You can clearly see the cecum or IC valve, and the tattoo is like 2 or 3 folds. Polyp is 2 or 3 folds proximal to that, or the anal side of that. Then you can just mention that in the report, and there's no need for tattooing at that point. Sometimes we resect polyps piecemeal, which is more than 20 millimeters, and there's some additional prediction of reoccurrence, such as this polyp is difficult location, is behind a fold. You have used other means of preventing any reoccurrence, then you know that this may be a problem in future if you can't find this polyp. So it's prudent to just do a tattoo in that scenario as well. So this is the proper technique of doing the tattooing. So first thing you want to do is you want to prime the needle with saline, not directly the tattooing material, but the saline. Then advance the needle through the endoscope, approach and insert the needle into the mucosa at an oblique angle. Create a saline bleb, and why we do that? This is to reduce the risk of transmural injection. Then inject about 1 milliliter of tattoo per bleb. This is how you do it. It's a saline, then endoscopic tattooing, which is all of us use a spot these days. Injection needle, I prefer 23 gauge needle in this scenario. 25 gauge needles are available as well. So administer the tattoo solution. Flush the injection catheter with saline first. And then once the saline is in the catheter, then attach a shaken syringe containing the tattoo solution to the injection catheter. You already have about 2 cc's of fluid in the catheter itself, the catheter volume of saline. Then inject tattoo solution until it reaches the biopsy port. Sometimes nowadays we see some like Carlock needle, and there's another needle from a GI supply. They are opaque. You can't see where the tattoo is. Just inject a little bit of tattoo solution, not too much, maybe half a cc or so, and then you still sure that about half cc to 1 cc of saline solution is still in the catheter. Then puncture the GI wall. Again, it should be about 3 to 5 centimeters anal side of the lesion. Again, 3 to 5 centimeters anal side, which is distal side of the lesion. This will prevent any future submucosal fibrosis. If the tattoo really expands in the submucosa, it will not reach the lesion, and the resection for the referring endoscopist will be safer. So after the saline bleb is done, then tattoo material can be injected into the saline bleb. So for localization of polyps referred to interventional GI, as I said before, 3 to 5 centimeters from the lesion on the distal or anal side. For localization of polyps and scars, which we want to follow in future, again 3 to 5 centimeter distal from the resection defect. For the cancers which we discover and patient is referred for surgery, in this situation, we do recommend placing the tattoo in 2, 3, or sometimes even 4 quadrants, just distal to the lesion, so that surgeon can find this easily. A tattoo should never be injected directly into or underneath a lesion. That might be removed endoscopically at a later point in time due to the reasons I delved into earlier, because it increases the submucosal submucosal fibrosis, and it makes the resection difficult, and also perforation risks are quite high in this situation. As I said before, volume of the tattoo material should be about 1 ml per injection site. Usually for the lesions which are referred to the endoscopist for interventional endoscopist for resection, or the lesion you're going to follow later on, only 1 tattoo is necessary for localization. More tattoos really cause confusion in future. Clearly, you should be detailing the tattoo injection in the endoscopy report, and it should be photo documented as well. Institutional protocol should be implemented at each center about tattooing, like we discussed. What happens if tattoo is too close? We talked about it before. It will cause fibrosis. It will cause submucosal fibrosis, high risk of perforation, high risk of incomplete removal of the polyp, and it will lead to surgical resection. If it's too deep, it can cause peritonitis, perforation as well. Let's moving on to how to properly report Barrett's esophagus. Barrett's esophagus should be in 2021 reported by prior classification and nothing else. I do a lot of Barrett's work, and I get a lot of patients referred to me. I sometimes don't even have whether this is a long segment or short segment. It is just Barrett's esophagus in the distal esophagus. And sometimes multiple biopsies are in the same jar, so I can't even tell where the high-grade dysplasia biopsy is coming from. So it's very important to really standardize the reporting of endoscopic findings in the patients with Barrett's esophagus. This was developed in mid-2000s, and it was validated later, so it's really in vogue since 2011-2012. It is consensus-driven and has been validated. So there are really 3 things endoscopists need to detail. One is location of the top of gastric folds. Second is proximal extent of the circumferential Barrett's esophagus segment, which is a salmon colored mucosa. Third is maximal extent of any tongue or island above the circumferential extent. So circumferential will be called C, maximal will be called M. I would like you to just go through this chart at your leisure, at your home. This is in your slides. This is a comprehensive way of looking at, start from number 1 all the way to number 6, how to report. But let me simplify again. Dr. Raju comes to my rescue and give me a very simplified slides, and I'm going to discuss those in next 3 slides. So the circumferential extent, as I said as before, distance from the gastroesophageal junction, where the gastric folds, top of gastric folds are, to the highest point of the Barrett's mucosa around the circumference of the esophagus. So that's the circumferential extent. Also, there's some confusion with Heidel hernia. So Heidel hernia really is below the gastroesophageal junction part of the stomach. You really look for what we call it diaphragmatic impingement. So distance between diaphragmatic impingement and gastroesophageal junction is a Heidel hernia. If the distance is 2 centimeters, it's a small Heidel hernia. 3 and 4 centimeters is medium Heidel hernia. If it is 5 and above, it is large Heidel hernia. Also remember that the smaller number is always GEJ. The higher number is always the diaphragmatic impingement. It is important. So then, what is the maximal extent? It is distance between the GE junction and all the way to the top of the Barrett's esophagus tongue. That's the maximal extent. So your C number will be either smaller or equal to M number, because sometimes all the Barrett's esophagus is just circumferential and it is not, there's no tongues or islands. And so C number will be always equal or bigger than the, or smaller than the M number. So how do we report this? Let's say the GE junction is at 35 centimeters. Let's say squamocolumnar junction is at 31 centimeters. So that will be reported as C4. And top of Barrett esophagus tongue is at 30 centimeters. So that will be reported as C4M5. That's all I had for you today. And if you are attending the conference live, we'll be happy to take questions on this topic. Thank you so much. Appreciate it.